Hi, everyone. Thank you so much for joining us today for what is the 16th in Physicians for Human Rights, PHR, webinar series examining the COVID-19 pandemic through the lens of health and human rights. I have the great fortune of knowing many of you who are on Zoom today, but for those of you who are new to us, I'm Donna McKay, and I'm the Executive Director of PHR. For the past 4 months, we've been bringing together physicians and scientists and civil society leaders, policymakers on a very wide-ranging set of topics that seek to bring science-based analysis and approaches to help guide responses to this massive public health pandemic. Healthcare workers, scientists, and social justice leaders, like the 4 who you will hear from today, have been on the front lines of this pandemic, and these professionals and thousands others like them should be informing our understanding of the pandemic and policy decisions at every level. So our webinar series over the last 4 months has been providing a platform for these voices to be heard, and our massive media and advocacy efforts have been in support of them during this unprecedented time. We have almost 500 people live with us today to hear from expert panelists on the importance of rebuilding our global approach to healthcare as we think about chronic issues in our healthcare systems that have been even further exposed by the COVID-19 pandemic. And our panelists will discuss how this moment in time presents a very real opportunity to reconstruct current systems and better reflect healthcare as a basic human right for all. So I'm really thrilled to introduce today's moderator, Patricia Sellers. Patty's an international criminal lawyer and the special advisor for gender for the Office of the Prosecutor of the International Criminal Court. PHR is really fortunate to have her as part of our network of experts, and we're proud to have her as an engaged member of our advisory council. Patty served as a legal consultant to UN Women, the Gender and Women's Rights Division of the United Nations High Commissioner for Human Rights, and to the Secretary General's Special Representative for Children in Armed Conflict. She has lectured extensively on humanitarian and international criminal law, and she is an incredible advocate. So I'll now turn over this conversations to your hands, and thank you so much for leading us, Patty.
Okay, thank you, Donna. It was a lovely introduction. Am I muted? I'm unmuted now, right? Okay, great. Okay, I'll start again. Today we have a stimulating panel, and we're going to engage in a conversation about how we get to the future, hopefully a future without COVID-19. The panel might also address what, if any, positive imprint COVID-19 has left that can then shape our societies, our world, and our community to ensure survival after this pandemic. To understand where we are, the feminist analytical tool of intersectionality is going to be used. That's the confluence of disparities. It's a vital starting point. We might reprise discussions of the intersections of social class, race, caste, gender, disabilities, or migrant status to comprehend where we currently are and how the devastation stands within our communities. Today, the effect on patients, on victims, on health workers, on families, and yes, I might add, on world politics and the economy is teetering. Are we teetering toward oblivion or salvation? Are we severely weakened, or are we beginning to rise like the phoenix? And does surfacing these intersectional realities really prod us to construct a better world? Well, if so, how? Today, we aim to challenge our own imagination. We want to do a little future think. How would our imaginary future selves appraise this moment? How did we navigate to a future for better outcomes for local, national, and the international community? A precept or norm in international criminal law, the field I normally deal with, such as the law of crimes against humanity or genocide, deals with individual acts that might be inflicted on one person, but that recognize that the harm is to the group. It is the group, the collectivity, that is targeted. One act of persecution or genocide really inflicted upon an individual means that a racial, a national, an ethnic, or religious group has been attacked. The same way with crimes against humanity. It means that the civilian population has been attacked. And so I would pose the question, and I really wonder, are the harms that we're receiving now, often very individually through COVID via one patient, or the stress of one healthcare worker, or the intense stress of an essential worker in a food store. Isn't this really a collective harm to our communities and to our international community? Can we future think a positive international outcome, an intersectional international outcome for our own collectivity? Well, to help me decide those questions, but more importantly, to posit some answers, we have this brilliant panel. First of all, we have Dr. Ayanian, who is an MD, MPP, and he's the inaugural director of the Institute for Healthcare Policy and Innovation at the University of Michigan Medical School. We also have Dr. Giselle, she pronounces it in the French way. Myself being here in Brussels, I'm very happy to know that. Dr. Giselle Corby-Smith, MD in MSc. She is the founder and director of the UNC School of Medicine Center for Health and Equity Research. And she's a keen and distinguished professor in the Department of Social Medicine and Medicine. And we also have Dr. Rashmi Goshawan, PhD. And she's a feminist, an advocate, a human rights activist for years, I won't say decades, Rashmi, okay? And she's done pioneering feminist work throughout South Asia and throughout international spheres, including the United States and Canada and Europe. She's a member of the Bureau of the South Asians for Human Rights. I welcome all of you, and I hope that you're all in good health, mental, physical, and spiritual. Well, let's get started. First round of questions. And I'd like to ask you, from your immediate view, where you sit now, the work that you're doing now, how do you understand the disadvantages of COVID and its advantages? I'd like to start with Giselle.
Patty, thank you so much. I'm truly honored to be amongst these thought leaders and to have been invited to be part of this panel. Well, you know, what we have seen in inequalities around COVID-19 and this pandemic have been deeply distressing. But unfortunately, for many of us that have been in this work for quite a long time, there are no surprises. This has revealed the structural inequalities and structural violence that we know exists within our healthcare systems, within our public health systems, and within our communities. We, as you mentioned, Kimberly Crenshaw's intersectionality theory, we've seen this sort of intersection of medical, economic, and social vulnerabilities play out for as long as we've been measuring inequalities, looking at things by race, social class, etc. And what we see now is just a blatant example of that, and of a system that has been created that gives us the outcomes that we're seeing now. What I will say is that looking forward, the financial and human toll on already strained systems and communities will be staggering, much beyond where we see now. It's going to be multifold and have long-lasting sequelae. And I think we need to be prepared. And this is the right time for us to be thinking in how do we prepare ourselves and prepare our communities and organizations to be able to be resilient, to be able to bounce back from this insult. Appropriately, we're focused now on this acute insult, but we absolutely need to be looking forward to make plans now so that we can communities, individuals, and countries can come out stronger.
So we almost don't have the luxury of just remaining in the moment we're in.
It is, yeah. I think that we need to really be, we know what we know now, but what we know is that these bands of structural inequalities are strong and deep. And if we're not intentional and forward-facing, they'll snap back to where we are now and where we have been. And one last thing that I'll say is that the fragmented pandemic response, at least in the United States, and I would say probably replicated in other parts of the world, has done little to demonstrate the trustworthiness of medicine, science, and public health. And it's going to create barriers for our future research and programs. And that's another piece of this that we're going to need to attend to if we have any hopes of ever containing this pandemic.
So research must also be part of what we think about in the future. John, can I turn to you? Where you sit now, tell me some advantages or disadvantages.
Sure. So thank you, Patty. It's a pleasure to be here and welcome everyone from the Physicians for Human Rights community joining us today and my fellow speakers on the panel. This is a vitally important moment in world history and how we come together as a community. I am a physician and professor, and I direct a campus-wide Institute for Healthcare Policy and Innovation at the University of Michigan. And we were one of the early hotspots in the United States here in southeastern Michigan, along with New York City and New Orleans and some other areas of the country. And what's, I think, frustrating is that we're not yet showing much evidence of learning in the United States of how to cope with this pandemic. We're seeing it sort of roll out in successive waves across the country, and other countries around the world are experiencing this to a greater or lesser degree. But to me, it really highlights, at least in the United States, some of the divide we've had between medicine and public health, and the fact that we've continued to invest heavily in our healthcare system. Obviously, we want people to get the healthcare they need when they need it. But to some degree at the expense or at underinvestment in our public health system, and making sure that communities and early warning systems and integration of social services that people need in a pandemic are as strong as they can be. And I think that's where we have much to learn, both from what's gone wrong in recent months and what we need to do better going forward. Historically, medicine and public health do not need to be separated, but too often they have been. And I think we need to learn from colleagues and partners around the world where there's better integration of those two systems, and to really understand, and then bringing the economy in. Obviously, we're all grappling with the economic crisis that's come with the public health crisis. But in my view, we can't solve the economic crisis and help communities in need unless we solve the public health crisis. So
we have this untenable divide between healthcare, almost individualized healthcare, but yet public health, which is the concern of the community. And I'd almost want to ask our panelists, aren't we only as healthy as the sickest among us? So we both need good public health care and health care. But I'm going to turn over to Rashmi. Rashmi, you're sitting in Shillong, India. From your vantage point, near the Chinese border, near the Bangladeshi border, but ensconced in India, what are our advantages and disadvantages with COVID?
Yes. Thank you, Patty, and thank you, Physicians for Human Rights. I am very honored to be part of this very important and critical panel, and with such important speakers. Well, one is caught between being optimistic of what this moment kind of offers in terms of opportunity of reimagining a future, a feminist analysis of the future. And Patty, as you say, if we adopt an intersectional approach, then there is so much that we can change. But let me start with the negative first. As everybody said, this is a moment where deep, deep structural divides, structural inequalities have surfaced. As renowned scholar, Professor Upendra Bakshi recently commented, if the spread of a global pandemic was an act of misfortune, its catastrophization has to be located in the injustices of social structure and policy. And I think that is where we need to start. If we are imagining a future post-COVID, we need to definitely look at the injustices of the social structure. We need to look at the ideology, the political ideology that underpins policies at this moment of time. And only then we can move to a future. The structural inequalities in India and the vulnerabilities are very, very sharp. It has played out, in a very, very brutal manner. It also, I need to put this in perspective, that it's important for us also to flag that the pandemic also happened at a particular moment of history where things across the globe were really falling apart. we were in some kind of, we have a health emergency now, but when it started, we were actually in the throes of a political emergency, and this was across the globe. You know, we had democracies being dismantled, institutions dismantled, a level of authoritarianism, of divides and so on. This is the context where the pandemic then came in. And if we are going forward and trying to change things, we have to also repeatedly bring to mind the political context in which the pandemic today is being played out. And why I say this, because it's so complex in India. I mean, what are the three, in my view, there are three very, very sharp categories of vulnerable and high risk people. First of all, the health system itself. We have followed a neoliberal policy of privatization of India has been promoting, tourism, health, medical. India has become a destination for medical tourism. But what is the reality in India? Only 1.12% of our GDP is for public health, which is even lower than other countries. In South Asia, we are below Sri Lanka, which is at 3%. Even Nepal is higher than us. So on the one hand, we have this very grandiose plan of India aspiring to be a global leader, of offering India as a destination for medical tourism. And on the other hand, the reality that this pandemic is thrown up is our public health system, which is absolutely pathetic.
Well, excuse me, I would just break in there because all three of you have seemed to put such emphasis on public health. So it's almost a contrast in the individualization of the specific victim, but what I'm understanding you to say is that you cannot unlink now public health from health systems and maybe from politics. Well, let me do a little slight shift on you, okay? When we're thinking of public health, in many ways, we're thinking about the physical well-being of the individuals in communities at large. What about mental health? I mean, isn't this also a pandemic that has attacked us mentally? I mean, I've heard, I think Giselle speak before about wellness, and I know John is very much into understanding resilience, and then the other side of resilience, which could be trauma. So speak to me a bit about this other important, vital part of our individual and community health, if I could say. John, let me turn to you.
Thank you. That's a very important question. And it really speaks to the fact that this pandemic has affected us, not just physically, but mentally, in terms of the isolation that's been required, in terms of some of the distancing measures and the wearing of masks and the sheltering at home when possible, to reduce the spread of the virus, the coronavirus that's causing this pandemic. And all those changes to our daily routines, the need to work remotely, the closing of schools in many countries, the changes in childcare routines, the inability to see older relatives who may be particularly vulnerable to the physical effects of the virus, but they're also especially vulnerable to the social isolation and the mental health effects that go with some of our necessary public health responses. So, I think that's another area, I think we're all agreeing on the need to integrate the role of public health and healthcare, also integrating concepts of physical health and mental health, and understanding that they're vitally connected. And in many countries, we don't invest enough in mental health services at the individual or the community level. And, and I think that's one of the ways where we're going to have to respond coming out of the pandemic, because we know many people are suffering in terms of their mental health. And yet some of what came out early on was the mental health of our frontline healthcare workers. Some of the evidence we initially had from China, and now more recently from the United States and Italy and other countries, there's incredible stress in caring for the victims of the COVID-19 pandemic who require intensive care or prolonged rehabilitation. And those mental health effects are just permeating all of society, not just among healthcare workers, but among all of us affected by the pandemic.
Well, Giselle, how can we get to this wellness, this future wellness? How can we be mentally, I almost want to say emotionally as well as spiritually well 5 years from now?
Oh, thank you so much for that question, Patty. And I just want to go back and just underscore how much this pandemic has revealed the fault lines between medical care and public health, the acute care versus the investment in a long-term program to support prevention and wellness, and how so many of our communities are left in the brink. Not just this pandemic, but really in so many ways when they face community disasters, whether it's hurricanes, tornadoes, natural disasters, or man-made disasters in terms of gun violence. So I think what I have been working on with and thinking about with our communities is how do we actualize and put into practice the idea of community resilience. The Robert Wood Johnson Foundation and RAND developed a framework around community resilience that elevates the idea of connectedness between organizations that's community engaged, and that allows us to think about not just the emergency response to a community disaster, and as a separate framework, but as an integrated framework that when there is not a disaster can actually be leveraged to prevent chronic conditions or to support the idea of whole community health. So a concept that goes beyond just the physical health of individuals, but thinks about social capital and connectedness, thinks about the way information flows between and across individuals and organizations, creates a fabric for a community that goes beyond just the physical well-being of individuals.
I remember I once did a consultancy in Haiti for one of the few remaining buildings that stood after the earthquake. And it was a building that was a children's center. It had been designed by architects to make sure that it would not crumble during an earthquake. What it provided was physical assurance and mental assurance for those children. And so that's an example, a bit of Giselle, of what you're saying. But Roshmi, I think you started to talk about what I'm going to term could be almost political depression prior to the pandemic. And so if we add on certain political conditions that people feel that they're undergoing, having to submit to, whether it's decreasing democracy, rising authoritarianism, and then the mental effects of being in a pandemic. Can you speak a little bit about that and maybe certain populations who would feel it more?
Right. Thank you, Patty, for that very important question. In fact, this is, I agree to all of that John has said and Giselle has said on mental health, but I did want to bring out the special mental health conditions of one category of people who at this moment are extremely, extremely high risk and vulnerable. And these are the political and civil liberties activists, human rights defenders, and others who have dissenting voices, who were either already imprisoned before the pandemic started, or ones who have been picked up during the pandemic and thrown into jails. So this at a moment of the pandemic, we have just now, before coming into this webinar, we get information of an 80-year-old poet, professor, who is now been, he is been identified COVID positive. So there are many such people in jail at the moment. There have been repeated petitions filed saying that they are high risk. There are people who are senior citizens, that they are high risk, that they have comorbidities, that they are very vulnerable to the COVID, being infected with COVID and coming out positive. But there has been no respite. Bail petitions have been rejected time and again. They remain under trials. It is difficult for the families to do much during this period of lockdown, where you are you have to be in your homes. So it is like it's a kind of mental health situation for a whole interconnected people. It's the people themselves who are in jails. It is the families. It's people who are moving around trying to do something for them. So this is huge at the moment, one after another. All of the political prisoners, all of the human rights defenders who have been imprisoned during this moment of the COVID, one by one, they have been put in overcrowded prisons, and one by one, every second day, we get report of one more being infected. So this is a huge
community of human rights defenders, or let me say opposition types of political leaders, who we see that they've become the victims of COVID, even if they aren't sick, but the political thought or the resurgence of a political democracy seems to be victimized. I'd like to talk about other subgroups, and particularly about essential workers. I mean, where will their centrality be 5 years from now? Migrant workers. Are we in a wonderful let's hand bread and roses to the nurse's aide today, who we will deny her or his existence in 5 years? So talk to me about this. How can we make sure that the centrality that we claim that essential workers, including migrants, have remain central and are still recognized as being essential 5 years from now? John?
So that's an important question. I think a lot of it in the near term has to do with how we create safe working conditions for people. In this still acute phase of the pandemic, we have to make sure people have the protective equipment they need, whether that's masks or face shields or gloves and gowns, depending on the type of work they do. We see this in the food processing plants, the meatpacking industry, for example, in the United States, where we've seen significant outbreaks. We've seen it among, as you mentioned, the aides and others in nursing homes and long-term care facilities, caring for some of our most vulnerable elderly and disabled members of society. But I think the challenge then is, even while we apply those Band-Aid approaches and make sure that in the near term people have the protective equipment they need, how do we create safe and respected work environments? We're seeing more appreciation, for example, for grocery store workers that make sure we still have the food we need to eat. But those can be challenging, physically demanding jobs with tough schedules. How do we make sure that that appreciation continues after we get this pandemic under control? I think that's where some of the political will comes in, in investing and having standards for how people at kind of all levels of occupation in society are respected and ensure that they have a safe workplace. And that hasn't always been a priority, and many of these jobs are hidden in times other than the pandemic. So I think that's something where we need to come together, our political and social and business leaders, and try to understand how we make those occupations much safer and more rewarding.
Right. Shazam, I'm going to turn to you, but I mean, what I would want to interject is part of it is very much a social construct, whether it be low wage or whether it be internal economic migration. And part of it is an economic construct that we don't want to pay certain workers more, although we certainly want to have the avocados, and we want to make sure that the sushi is rolled up nice and tight and that the towels are fresh in the hotel. Are we talking about maybe re-evaluating not only our societal but individual and correlated worth values as we come out of this pandemic, so that essential means and stays essential, and it's given the economic and political worth that today we claim it should have?
Patty, thank you for that question. It's a very personal question for me. Many members of my family are essential workers in the New York City area, where the pandemic hit hardest in the United States early on. Post office workers, warehouse workers that were providing supplies to homeless shelters, transit workers. These are my family members. And so I've seen up close the impact of this pandemic on my family, and those in my family that are considered essential workers and frontline workers. And I still think that though there's work to be done in terms of the valuing of the work that these individuals do. We saw, and I was so grateful for the acknowledgement of our healthcare frontline workers. But my family members in New York City said, "Well, what about us as essential workers? Why don't we get applause or bells rung at 7 p.m. every night?" And because they're just as at risk, and in some cases more at risk. One of my family members who works for the New York City Transit was actually told early on in the pandemic, that not to wear a mask because it would frighten subway riders. So the risk is real, and part of it is misinformation. Part of it is what we knew at the time, but the reality is the valuing of all of our human lives I think is at the core of what you're suggesting, whether it's in terms of appropriate economic reward for the work that they're doing, making sure that they have the health insurance that they need, or can access healthcare in a way that reflects the kind of risk that they're taking. I think that we could really think broadly about the kinds of supports, the mental health supports of being on the front line every day because you're an essential worker, what it means to call out, what it means to wait for that test, as my brother had to wait for the test to see what came back for him. So how do we build around the supports for people that we consider essential to keep our society running?
Right, Roshi, I'm going to turn to you for that question before we turn to our audience. And I'd like to know, could you say a little bit about the situation of internal migrant workers in India? Because that certainly has hit the international, meaning outside of India, news.
Right. Thank you, Patty. That question is actually very close to my heart as well. Across the world, we know what happened to the Indian migrant workers when a lockdown was announced, and on the 24th of March, and people were given 4 hours, notice, 4 hours notice. The reality is 90% of the Indian workforce is employed in the unorganized sector. And of this, 90% millions work in urban centers, building our dream cities, our bullet trains, making India look what it is beginning to look like now. But I think the migrant workers situation, just kind of with a 4-hour notice to social distance when they barely have a little bit of space to sleep in, and where is the social distancing? There was no transportation. So we've seen images over and over again of hundreds and thousands walking home. So what does it tell you? What does it tell you about the security for these people who actually hold India's USD 2.6 trillion economy, who are behind that economy? What does it tell you? That there was no social protection, there was no health protection, there's no housing rights. So there has been a great awakening across the country, because the plight has been so heartrending and devastating. I'm not sure, and I do hope that kind of understanding remains, and that in efforts of people who will be in the front line to ensure that the migrant workers' rights are protected, and that they have access to social protection, health protection, and so on, that there will be greater endorsement from Indian citizens on the whole. So that's the migrant
solidarity among citizens, but there has to be some type of solidarity among citizens, but much more than that, there has to be some competence within our political will and our economic will.
Absolutely. I mean, it goes without saying that the political will, by the time the pandemic is over and something has to be done, we hope and we will push that it does not die down. I see there is already a dilution. There's far less discussion around migrant workers, and there are more offhand kind of, okay, this transport has been provided and this has been done and so on. But it is an issue which threw up in a big way, showed the whole world what India is all about. It's something that cannot be given up. It has to be there in the political manifesto of each and every political party in going forward for elections, that this is an issue which has to be addressed.
Okay, well, we have a question from the audience and they want us to really say, well, what are the reforms? What are the reforms that should be suggested and put forward in terms of the public health system and the medical system, so that there can be a better integration between the individual and, let's say, the community in terms of health? What are next steps? And if you could name 50, I would appreciate that. No. The beginning 3 is fine. John, what about you?
I'll suggest one that I think is very important, which is investing in our safety net healthcare providers, which in the United States very often are community health centers in urban and rural areas. They tend to have a real focus on community health and integrating medical and social services. When they function well, they're vitally important for some of the marginalized individuals and communities that we've been discussing today. When we look around the country, those are some of the parts of the healthcare system that have been hit most directly. During March, April, and May, many of the areas that were starting to experience outbreaks of coronavirus had to shut down all their outpatient medical care and their elective procedures. And so places like community health centers or physicians' offices in underserved communities, in essence, had to shut their doors except for emergencies, and they suffered significant financial consequences that they will take a long time to recover from without help from our state and federal governments. Some of that help has begun, but probably much more is needed. And I think we need to prioritize funding for groups like community health centers that are most in need in serving the communities and the marginalized groups that are affected by some of society's fault lines. The other piece in the United States is making sure people have good insurance coverage. There are large parts of the country, particularly in the South, that have opted not to expand Medicaid. Some of the states that are being hit most directly, like Florida, Texas, Georgia, South Carolina, haven't expanded Medicaid to all low-income adults that are now eligible in 36 other states around the country. So I think we need both individual support through better insurance coverage for low-income individuals, and then a better system in strengthening our safety net through the community health centers and other providers in those communities.
Giselle, what would you say in terms of next step? And if I could preempt it, what would you say in terms of preventive care and aftercare?
You read my mind. I'm going to talk about preventive community care, though, and then talk about individual. So, if we think about, again, that intersectional lens that Kimberly Crenshaw talks about, intersecting streams of oppression and the vulnerabilities that result from that, then we need to think about how is it that we, at least in the US and across the world, are at a point where we're not investing in those communities to right those wrongs. The policies and practices that flow from that structural inequality and make up the social determinants of health, the conditions in which we live, work, and play, pray, age, is, I think, to me, is part of the prevention that we need to be thinking about. And this is a long game. This is not something that's going to fix our inequalities today or tomorrow, but it's an intentional approach to this. Another, if I could continue to draw this metaphor analogy around intersection and intersectional theory, we're at the intersection of a global pandemic and a global rebirth of a civil rights era, and an acknowledgement of discrimination in our communities, in our organizations, institutions, and countries. We need to take advantage of this moment at this intersection and really be thoughtful about the reinvestment in communities that have been historically marginalized or underserved. How do we ensure, again, that we have a workforce that can respond appropriately, either in the healthcare system or in a public health system or in the grocery store, appropriately to the work that needs to be done in the setting of a community disaster? How can we knit those organizations together to create a resilient community where there's a focus on wellness and health rather than on illness and disease? That's the prevention framework that I would offer for us to start thinking about. It's a much broader lens, but I think, you know, if we're talking about prevention, this is what has been eroded in our communities and why this pandemic has been able to impact individuals disproportionately. To go to the individual, as I said, high blood pressure, cancer, you know, strokes, heart disease, these don't wait for a pandemic to be over. And so what we will see, I predict, that, you know, unfortunately, is that we'll see we'll have seen the effects of a lot of deferred care. And we need to have a prevention structure in place, a treatment infrastructure in place so that we can support individuals and communities that have already disproportionately borne the burden of chronic medical conditions, and be prepared for that shadow pandemic coming up of unmet chronic disease risk.
Well, then that leads us into one of the questions that the audience is putting forward now in terms of commenting. I'll ask Roshman to do it. When certain groups are persecuted because they're the so-called hotspot, they might be the carriers, they believe, of COVID, and particularly if they're malign groups such as migrant workers, or within the US, it could be also migrant workers or immigrants who are working in meat factories. So this type of persecution that comes from having the disease that we know does not knock on the door and ask, who are you, may I come in? But that just looks for the body in which it can live and eventually kill. So what should be our human rights reaction or our social political reaction to this type of persecution that's almost prompted and propelled by fears of the communities, and then to say that these are weak or sick communities or carriers of the plague?
Okay, Patty. In fact, I was really thinking of the earlier questions that you had posed, and my whole thought was, if I had 3 points, my first would be...
I'll let you do that.
No, but it's connected, so I'm just saying it. So my first point would have been, we have to bring back human rights to public health, no matter what. In the Indian context, there has been a gradual dilution of a rights-based approach and of looking at health as an entitlement, as a right, to depending on the largest of the state and so on. So coming back to this particular question, of course it is a human right. Every human being has a right to healthcare, must have a right to the appropriate, adequate healthcare. Does not matter where you come from, and everyone, it's a universal right, human right to health must be re-established. In India, it becomes problematic. You raised some of the fault lines of, there are particular communities who are far more vulnerable. That's why I talked about the political context, because we have to keep going back to what is the political reality and what is the context in which this is playing out. And there are certain communities who are given all of our entrenched caste and religious divides. There are certain communities who are certainly targeted far more than others. And I feel only a human rights, a socioeconomic rights, human rights is the approach we have to take, and we have to take it in a very bold manner. I mean, we have to clearly spell it out, that this is the approach, this is what we have to do. Every individual counts, and we have to take that forward. And for that, I think the international mechanisms for ensuring human rights for all, whether it is socioeconomic rights, civil political rights, whether it is the different UN resolutions, I think one needs to revisit in terms of the pandemic and see what is it that they say or don't say about moments like that, where people become extremely and especially vulnerable, and certain categories of people. And I think we have to, as human rights activists and defenders, we have to revisit and rescope what we can take from the given mechanisms and institutions and how we apply that to our own context. I don't know if that answers the
Yes, but when you
question of
talk
how.
about human rights, and I'll open this up to the group, I mean, we can talk about the right to health, or we can talk about making governments at different levels accountable for the absence of health provision during the pandemic. But also, don't we have to understand that there's going to be a much more critical blending of how rights can be lost? And Giselle, I'm just going to go back a bit to your example. We were talking about preconditions, but we know that with COVID-19, that the after effects, the sequelas, can be very damaging. People who might have been healthy might now have long-term health issues that might come under the disabilities treaty. You know, persons who have diabetes, dialysis for the rest of their life, or people who now have permanent injured bodies, although those are viable bodies in terms of being alive. So it's a cross section. The United States has not signed the Disabilities Convention. Okay, so Americans do not have protection under that. The right to health has been sometimes placed on the second level within international human rights movements. And when we talk about whether it be individualized health providers or community health, that's rarely placed within a human rights context of what different governments owe their citizens, as opposed to, Roshni, as you were saying, the privilege. So, I mean, if we kind of wrap ourselves around on all the different levels of human rights, do we lose the picture of doing community organizing or making sure that the healthcare system in which we live is correct if governments aren't paying attention to human rights? Would that be a bit of a loss of our energy and effort in the next 5 years? John.
Yeah, I think everything you're saying and Roshni has outlined it, it goes hand in hand. Human rights do go hand in hand with health. Each country and society has to approach that to some degree in its own cultural context and political context. But I think we also have opportunities to learn from each other across the globe. In the United States, elections matter, and I think it's very important for people to see this as a moment in a democracy to be politically engaged and to pay attention to the candidates who are running, what their principles are, what their commitments to human rights and other policies are, and to re-engage in the political system. I think, over time in the US, we've had a gradual decline in political participation, but I think with this moment in time, with the pandemic, the emphasis on racial justice and the racism that many people are protesting against in our justice system in the United States, my hope is that energizes people to engage in the political system, because we have a representative democracy and we can only achieve some of the goals we're discussing today if people participate and vote and and mobilize as a community to express their preferences for the policies that they believe should be prioritized. So, it's those of us in academic or political or business roles, we can help to stimulate that discussion, but we also need to partner with community leaders and community members to really advance those principles that, are the ones that people prioritize for themselves and their communities.
Well, John, I take exactly what you're saying, that this part of our answer will be political. And I remind you, India's billed as the largest democracy in the world. And I believe that you last year voted in elections for your current leader, Modi. And there are some issues of is democracy voting itself out of office in several countries. But to tie this a bit to one of the questions that our audience has asked, is a question about the youth. Not only the effects of the pandemic on the youth, but will the youth have faith maybe in voting, in entering into democratic processes of understanding that policies are set really at governmental levels, whether they be municipal, state, national, or international. So I throw that out to either Roshni or Giselle. What do you think?
Well, I'll just say that that's one of those bright spots of hope that I have seen, particularly and around organizing around police brutality, racial justice, at least in the United States and frankly around the world. The armchair advocacy and that sort of ability to affect and to galvanize using social media, using the tools that they are so facile with to make a statement has been just gratifying to see. The marches that I've been able to participate in have been youth organized. Children that are just barely a little older, high school children have been able to organize marches around police brutality. It's just remarkable to me.
So
And they
maybe COVID has politicized the youth to a greater extent than they might have been pre-COVID.
I think we could, yeah. I think that this is the moment where these issues of human rights have come together in a way that are galvanizing not just our youth, but people all over the globe. I do want to though underscore Rashmi's caveat and concern, which is that they're at risk. They're not just at physical risk because of their own violence against those activists, but there's an emotional and physical toll that can happen as well, and we need to make sure that we're standing up and supporting them in this work.
Mm-hmm. That's a wonderful solidarity thought. Okay, we have a last round for 2 minutes. You can resolve all the problems in the world or just say one of the things that you would hope would be present 5 years from now in our post-COVID-19 world. Roshni?
This is my moment to reimagine the future, right, Patty?
Yes.
Well, as a feminist, as you know, we keep imagining a different world. We've been doing it for decades. We keep reimagining a different world. We have been doing this. We have had positions starting from development to environment, to women, peace and security, to human security, to climate change. And we are clear what we want in that future. I think we want a kind of a breakdown, a demolition of all of these patriarchal, machismo, concept, neoliberal policies. This pandemic has shown you that none of this works. Finally, we are all equal. When the pandemic hits you, it hits you. And we have no rich country and poor country. It has equalized a lot of things. It's that kind of equalization has taken place. So reimagining the future is, the reimagination has to be done by a global community. It's not just this country or that country. It is globally we have to reimagine this. Not just reimagine, we have to reimagine, and then we have to ensure that this alternate world will actually happen. What I just feel that, we are so caught up with a country's global leadership, and how do we look at a country's global leadership today? We look at a country's global leadership in terms of their riches, in terms of their resources, in terms of their military prowess, and so on and so forth, in terms of the industries and, all of these things. But we've never thought of looking at a country's global leadership in terms of how robust is their healthcare system, how robust is their social protection system, how much of human rights are they actually people enjoy. I think in imagining the future, this is what I think is an opportunity. I know it's a pipe dream, it's lots of challenges on the way, but with the youth, I feel that this kind of imagining and making it a reality is a possibility. And
I think those are great pipe dreams. I join you. John, can I ask you about the future, and can I kind of slide in the fact that if there's a vaccine?
Yes, Patty. In fact, that's what I was going to focus on for my closing remark, that my hope, if we think 5 years forward, is that within the next year, we have one or more effective vaccines, but more importantly, that we have fair and equitable systems for distributing those vaccines to the people most in need, not just the people who are most affluent or have the best access to healthcare, and that we think about that globally, that we need to think about those inequities within countries and between countries, because I think we will have an effective vaccine, hopefully sooner rather than later. It's hard to predict right now, but when we do, we need an effective system for distributing it to everyone around the world. And I think a corollary of that will be ensuring that the mental health needs we've been discussing today and the physical health needs of people who've been affected during this pandemic before we have a vaccine that can prevent a severe infection, that they're well cared for and that we're supporting the communities where those needs are greatest.
Thank you. Giselle, I'll give you a 30-second place to put the bow on the entire world.
Well, I mean, my hope and dream is deceptively simple, and it's that we have an integrated, as a clinician, an integrated public health and healthcare system that centers equity, demonstrates the trustworthiness of those systems, and ensuring that everyone has an opportunity to live a healthy life.
Wonderful. I'd agree with that. I'd like to turn you back to Donna. Thank you very much, panelists. It's been a fabulous conversation. Donna, to you.
It's been an amazing conversation. I love ending on the hopeful note of reimagining, and I want to reimagine our next stage where all of you are in leadership roles and that your insights and perspectives are leading responses to rebuilding our healthcare structures and systems. You were amazing today, Patty, Giselle, Roshmi, and John. Thank you so much for this really important conversation. There were countless gems of insights throughout this hour. I've taken lots of notes. I know insights that all of us, including PHR, can prioritize in our work and our lives. And I also want to thank all of those who are joining us live or will watch this after the fact. We will continue to help amplify voices and perspectives such as those we heard today. And I hope you'll join our community, which has thankfully swelled in ranks over the last many months. Go to PHR's website or our social media sites, sign up to stay informed, but really importantly, sign up to learn what you can do to be supportive advocates to all of those who are on the front lines, and to ensure that a human rights lens is used in policy decisions throughout this pandemic and beyond. So follow today's panelists also on social media and continue to make sure that their important voices are heard and perspectives and their advocacy. And continue to tune in to PHR's webinars. A week from tomorrow, Friday, July 24th at 2 p.m. Eastern Time, I hope you'll join PHR for a conversation on COVID-19 impacts on Native American communities. We have Dr. Chris Beyer, who's the Desmond Tutu Professor in Public Health and Human Rights at Hopkins Bloomberg School of Public Health, another member of PHR's Advisory Council, and he'll moderate a really important discussion with Dr. Shakita Bell, Abigail Echo Hawk, and Dr. Spiro Manson. So please join us for that. And thank you all for being with us today, and please stay safe.
Thank you. Stay safe.
Thank you.
Thank you.
Bye.
Thank you.